Coming up next on Food for Thought, it's Diabetes University. This episode's guest speaker is Charlotte Gollobin. She'll be discussing the nutritional pros and cons of bariatric surgery. You're watching Food for Thought on MCTV. Everybody has to eat, but not everyone knows nutrition. To help solve this crisis, Food for Thought provides some helpful info to show how to eat healthy. Now, we don't promise to return you to your high school playing weight or that you'll be able to squeeze back into a size 8 dress, but we will help you choose healthy meals that are quick and cheap. Each episode is produced with the help of the Hospitality Management Department at Montgomery College and the Marriott Hospitality Center on the Rockville campus. Food for Thought is an MCTV production. You can view this program and many others anytime on our YouTube and podcast sites. Okay, so you've had the appetizer, now for the meal. Let's gather the ingredients and start cooking. In this episode of Food for Thought, we present a lecture given by nutritionist Charlotte Gollobin. Charlotte Gollobin is a certified nutrition specialist and licensed nutritionist in private practice in Bethesda, Maryland. With 30 years experience working with bariatric-related nutrition, her practice now focuses exclusively on providing nutrition support to patients who have undergone bariatric surgery, such as gastric bypass. Obesity surgeries are an increasingly common treatment strategy for obesity-related diabetes. Ms. Gollobin outlines the various nutritional deficiencies that result from these surgeries. She reviews the vitamins and minerals negatively impacted, specific nutrient deficiency symptoms, and treatment strategies. Diabetes University is a free informational program for the public that highlights alternative and complementary research and treatment for diabetes. It is sponsored by the nonprofit Diabetes Action Research and Education Foundation, known as Diabetes Action. Each spring, Montgomery College hosts Diabetes University. For more information about the Diabetes Action charity or its Diabetes University programs, go to diabetesaction.org.
There's an association between bariatric surgery and diabetes that you should know about. The organization that was formed originally was the American Society for Bariatric Surgery. And when they found over the years that after bariatric surgery, a lot of people who had diabetes beforehand, and many people have had bariatric surgery, have had diabetes beforehand, their diabetes went away after they lost 20 or 30 or 40 or 100 pounds. And so they've changed the name of the organization now to the American Society of Metabolic and Bariatric Surgery. And I don't want to spend too much time on this, but there's a growing consensus now to have diabetes surgery, and there have been international task force about it. This will not help with type 1 diabetes. We're talking about type 2 diabetes. But there's a real push now for doctors to encourage their patients to get it. It's serious surgery, but it's really very effective. There were in 2003, there were about 100,000 cases of bariatric surgeries performed. In 2004 was 140, and up to 2005 was 170. In 2008, it was 220,000. That's almost almost a quarter of a million people in the United States alone. Worldwide, there are 1.7 billion obese people with a body mass index, BMI. I assume you all know that that's a ratio between height and weight, with a BMI over 30, which is considered obesity. In the United States, 2/3 of the population is overweight with a BMI of 25 to 29. You probably heard that President Obama had his BMI was on the radio. He has a 22 or a 23 BMI, and they were getting worried because it was getting up too high. Half of those people who are overweight are obese. Morbid obesity, which is what the surgery was originally designed for, is considered a BMI of 40 or a BMI of 35 with high-risk comorbidities such as diabetes, hypertension, GERD, sleep apnea. There are super obese people with BMIs of 50 or more. and we have worked with patients like that. Of course, what these people need after surgery is lifetime follow-up and annual blood tests. Most doctors do it, not all, and daily nutrient supplementation because they simply cannot get the nutrients out of the food that they eat, and you'll see why. Okay, before surgery, this is a schematic of what the intestinal tract looks like. And let me show you where some of the nutrients are absorbed. In the stomach, for instance, iron, calcium, niacin, sodium, and fluoride are either released or absorbed. Calcium and iron are released in the stomach mainly. In the duodenum, which is this very small section of the upper part of the small intestine, very important, and in the Roux-en-Y gastric surgery, which is the most commonly performed surgery, this area is bypassed. And so you can see why people cannot absorb calcium, iron, B1, zinc, copper, selenium. And in the jejunum, which is the middle part of the small intestine, there's a proximal jejunum and a distal jejunum. Proximal is what's closer to the stomach. And in that part, that's another part that's bypassed in most of the surgeries. And that's where you absorb B1, B2, B6, calcium. You can see why all these nutrients are not being absorbed. In the distal part of the ileum, which had been bypassed in the older surgeries, and some of the biliopancreatic diversion was called, and not done as much now. They do more proximal work now, the upper part of the small intestine. But there are a lot of people out there that had this surgery and still cannot absorb things from the distal part of the jejunum. And magnesium and phosphorus, sodium, zinc, and the ileum, of course, is the lower part where some of these things are absorbed in different parts of the intestine, but you'll notice a lot of them are absorbed in the upper part mainly. And the ileum, one of the problems is vitamin B12 absorption. Now, B12 is normally released in the stomach from the food that you eat, and it's bound by something called the intrinsic factor. That's that little IF, is an intrinsic factor. And it has to be bound and carried down to the ileum. But you'll see, I'll show you the diagrams of what happens with the surgery, and that part of the intestine, that part of the stomach that secretes the intrinsic factor is bypassed. And so the food that they eat does not come in contact with the intrinsic factor and cannot be bound to the B12. So those people will never be able to absorb B12 very well and do need supplementation. And that's one thing I really stress if you have friends or relatives that have had the surgery. They do need B12. It takes a long time to develop the deficiency, but it's very serious. It's called pernicious anemia. And it takes sometimes 7 or 8 years to develop, but they cannot get it from the food they eat. Fat-soluble vitamins A, D, E, and K has some proteolytic digestion in the stomach, but what happens is bile salts and pancreatic enzymes are secreted into the duodenum, and that's the part that's always bypassed in the malabsorptive procedures. And so people cannot absorb fat very well, cannot absorb, the bile salts can't get into work until much lower down. Okay, the GI tract. The stomach normally is 1,500 milliliters. That's about a quart and a half, and that it would hold. The small intestine is about 15 to 20 feet long. The duodenum, that area that is so very important, where so much is absorbed normally, is only a foot long. And that's bypassed in most of the surgeries. The common bile duct here and the pancreatic duct empty into that part of the small intestine. The jejunum is 6.5 feet long, the ileum is 10 feet long, and the large intestine, or the colon, that large part that goes around, is only 5 feet long. After bariatric surgery, what happens is the two most commonly performed ones in the past. The Roux-en-Y is the one that's most commonly performed. And in your folder, you'll see a Y-shaped diagram, and you can look at this later. But what happens is, in the Roux-en-Y, The stomach is made very small. What had been 1,500 milliliters is now going to be 15 to 30 milliliters. That's a big difference. In the biliopancreatic diversion, which is the one that was done years ago and still being done, but not as frequently, but many people had it years ago because that's what they used to do. They left a larger stomach than the Roux-en-Y. They left a stomach was 200 to 500 milliliters, but they made a much more distal connection. And if you look at that page, you'll see that the alimentary limb is the area that goes from the stomach down. The way the surgery is performed is the stomach is resected, and then the upper part, they bring the lower part of the intestine directly to the stomach. So the food goes right directly into that. And then the part of the stomach that has been bypassed, and the juices and everything, the digestive juices, come down and are reconnected much lower down. They meet again at something called the common limb, which is where the digestive juices can digest the food. But it's a very much smaller area. And you can see in the Roux-en-Y, it's 300 centimeters. In the biliopancreatic, it's only 100 centimeters. So it's a very small area, and people who have biliopancreatic surgery usually have a lot of gas, a lot of diarrhea, a lot of malabsorption. And you can see where the bypassed area is much smaller in the Roux-en-Y and much longer, 150 centimeters in the bilio. This is what the Roux-en-Y looks like, essentially. You have the stomach is resected so that you have just a small pouch. The bottom part of the stomach is bypassed, and so that and the duodenum, where everything is secreted, doesn't come in contact with the food until much lower down where you see the common limb, and that's where the food gets digested in there. So you can see why there's a lot of malabsorption. There was a surgery called the vertical banded gastroplasty, which was common for a while. I don't know if you know anybody that had it done. They don't do it very much. It causes an awful lot of vomiting. You can see where the this band was put in. It was also malabsorptive, but down below, but very restrictive, and caused all kinds of problems. They don't do it very often anymore. And then the lap band. Now, a lot of people are having lap band surgery now. The lap band is just a band that's put around the stomach and can be tightened or loosened. It's just restrictive. It's not malabsorptive. So people will lose 50 or 60 pounds and then could gain it back very quickly by eating anything they want. Milkshakes will go through very nicely, and they'll gain all the weight back. So it's a procedure that was developed originally for patients who were super obese to help them lose maybe 50 or 60 pounds first and then go in and do a Roux-en-Y. But a lot of patients are opting for this now because it's not as dangerous as surgery. It can be done in 20 or 30 minutes, as a matter of fact. It can be done nowadays with one port, just one incision in the stomach, one little tiny hole, and they can go in and do this. And so it seems like a very quick fix. Unfortunately, it can be defeated very easily. These are some of the old surgeries, the jejunal bypass, the biliopancreatic diversion is the one I was talking about before. That was done very frequently, this middle one, and was caused all kinds of problems. And then there was something called the duodenal switch, which was popular for a while. This one at the end, where they left sort of a banana-shaped stomach. They cut off the rest of it. But again, this also was malabsorptive as well. Now, another thing that's on this green sheet that you'll see is a new surgery now that they're doing called sleeve gastrectomy, which essentially is a lot like the duodenal switch, except that it has that same banana-shaped stomach, and they've removed the larger part of the stomach, which is the part that stretches a lot, by the way, the fundus area. You'll see pictures. It's something new, and they're hoping that it will, because it bypasses the area where ghrelin which is a hormone that involves hunger and appetite. It bypasses that area. They don't really have a lot of data on it because it's a fairly new surgery, but the data that they have shows that it is more effective than the lap band. Okay, there are many deficiencies in the literature, and I will talk some of the ones that are most frequently discussed. Vitamin D and calcium, iron, vitamin B12 or cobalamin, vitamin B1 or thiamine, and fat-soluble vitamins. And there are many more deficiencies, believe me, but these are the ones that you see most frequently. The vitamin D deficiency in adults is called osteomalacia. In children, it's called rickets. It was reported previously only in the very malabsorptive procedures, and now they're finding that it's a consequence of almost all the procedures. There's a deficiency in the general population, people who haven't had the surgery. In the United States, 80 to 90% of the people are vitamin D deficient. And the range, by the way, is now 32 to 100. It used to be 8 to 45. And so if you had a vitamin D level of 12, the doctors thought you were fine, and now it's very deficient. Let me explain. Vitamin D, if you get out in the sunlight in the summertime, and at our latitude, between April and November is the only time the sun will do you very much good. Between November and the following April, it's wintertime, and the angle of the sun is such that it won't help unless you go down south, go to Florida or the islands or something and get out in the sun. But what happens is the reason you get vitamin D, you make your own, is that you have something called 7-dehydrocholesterol under the skin, and when the ultraviolet light hits it, it changes into pre-vitamin D3 and travels through the bloodstream, goes to the liver, and it's converted to 25-hydroxy, and then it goes to the kidney, and it's 125-hydroxy. So these are the active enzymes, the active hormones. Anyway, vitamin D deficiency, called secondary hyperparathyroidism, osteomalacia. The blood tests that we recommend are 25-hydroxy vitamin D. If that's low and calcium is low, alkaline phosphatase is high, which is the enzyme that's involved in bone turnover. And the PTH, which is parathyroid hormone, is high. You have to look seriously that it's people are getting osteopenia and osteomalacia. Symptoms, the symptoms can be a little bit general at first. General aching, loss of energy, diffuse skeletal pain, bony tenderness, waddling gait. I saw one patient who had not taken any vitamins for 3 or 4 years, and she was only 29 or 30 years old. She had the surgery when she was 26, and she thought she looked great. She was, thin, and she was feeling good, but she wasn't taking the vitamins, and she was walking around like a little, sick old lady. It was sad because the bones in her pelvic area were giving her so much pain she couldn't walk. Muscular weakness and pain, and then of course hypocalcemia and tetany. Tetany is cramping, and you can get cramping in your muscles of your calf, and many people probably have had it, but they could develop severe tetany, and the muscles in the arms and feet, the calf, the thighs. And guess what's a great big muscle is your heart, and that's not a good thing to be. It's deficient in vitamin D. Treatment, high doses of vitamin D2. The doctors are prescribing these little green pills that have 50,000 international units of vitamin D. I will tell you that we've seen patients who are needing 150,000 a day, okay? The water-based vitamin D, D3, they were trying to do some studies at NIH. I don't think they ever finished it because I've never seen any results of it. You can buy vitamin D3 in gelatin caps, and you can get them in 1,000 international units, 2,000, 4,000, 5,000. Researchers are recommending a lot more than your doctor is telling you. The recommended dietary allowance is 400 international units, and the doctors are now starting to say 1,000, and the researchers are saying 2,000, 4,000. Some people need twice that much. So, okay, iron. Iron is released in the stomach. It's absorbed in the duodenum. Remember, that's the top part of the small intestine, which is bypassed. And the proximal, closer to the stomach part of the jejunum. Deficiency very soon after surgery. Large supplements are necessary, and women who menstruate are at increased risk. And the blood tests that we do, these are things that I have done. Not all doctors do this. They should, but they don't. If the hemoglobin is low and the hematocrit are low, your serum ferritin, which is a storage form of iron, is low, and your serum transferrin, which is a transport form of iron, is high, it usually indicates iron deficiency. Vitamin B12, which is cobalamin, deficiency, again, remember I told you it's secreted, the intrinsic factor binds the B12 in the bottom part of the stomach. And many surgeons are now prescribing acid blockers to prevent ulcer formation. And so you need an acid medium to absorb this. You need an acid medium to absorb calcium and iron too. And a lot of the patients who are taking these acid blockers are becoming more and more deficient. Anyway, symptoms. Demyelination, you get demyelinating lesions of the spinal cord. Myelin is a sheet that covers the connections between the brain, the nerve cells in the brain. And in severe B12 deficiency, later on, it takes years to develop, but you can get it, you demyelinate, and it's like getting an electrical cord that gets breaks in it, and you get sparks flying. And this is what happens to the myelin sheath, and there are a lot of mental problems that can develop, serious problems. Lesions in the brain and optic nerves, painful paresthesias, pain in the extremities, in your feet and your toes, your hands. Loss of vibration in your hands and your toes. Glossitis, which is inflammation of the mouth and the tongue. Mental changes, and of course pernicious anemia, which is after 7 or 8 years you can develop that, and it's deadly. Okay, blood tests that we do, we recommend. When the red blood cell count is low, the MCV on your metabolic panel, when that's high, you mean cell volume, hemoglobin and hematocrit are low, methylmalonic acid is a specific test for B12. If that's high, and when I order it, the doctors see methylmalonic acid being high, they say to the patient, oh, you don't need any more. It's wrong. When it's high is when you need it, okay? When it's low, it's all right. And homocysteine, which a lot of you know about and very often are being checked for that now, when that's high, you don't have enough B6, B12, and folic acid, the levels go up, and that can also be an indication of B12 deficiency. The supplementation is intravenous, 1 milliliter per month, 1,000 micrograms per milliliter. Some people need more. Some people only need it once every 2 or 3 months. Some people need it every week. And there's also a sublingual that you can put under your tongue, and 2,000 micrograms in a sublingual per day. But I don't think that works as well. It's supposed to be absorbed as well, but I think over time. No one's done a study on that. But intravenous, it's getting into the bloodstream directly. Okay, thiamine, which is vitamin B1, usually happens right after surgery. You get serious problems. People started vomiting. And when there's a lot of vomiting, it can, right away, you got to be suspicious of a B1 deficiency. In the old days, it used to be called beriberi. I don't know if you remember that. And there were 2 types. There was a dry beriberi and a wet beriberi. And the dry beriberi is a neurological one, which affects tendon reflexes, muscle weakness, polyneuritis, many different nerve problems, pain, convulsions, Wernicke's encephalopathy, which is again a neurological thing, confusion, ataxia, problems with the eyes, and psychosis, and eventually coma. The wet beriberi is cardiovascular, and you can get heart enlargement, tachycardia, irregular heartbeats, edema of the legs, bounding arterial pulsations, heart failure, and lactic acidosis, which can be fatal also. It's a buildup of lactic acid in your system. Now, there's a very, very serious kind of cardiovascular beriberi, the wet beriberi. It's called Shoshin beriberi, and it happens very quickly, and it's very acute, and it has to be caught immediately, or a patient's going to die. It leads to death within hours, and it has to be recognized very quickly, and it's not always recognized very quickly, but it doesn't happen very much now. It used to happen years ago when people were not aware of some of the complications. Blood test, again, blood lactate, serum B1. Treatment, 50 to 100 milligrams intravenously or intramuscularly every day until the symptoms disappear. APGARs is something that it's called acute post-gastric reduction surgery. It's a terminology that was established in 2002 by the the American Academy of Neurology, and it's just a lot of the same symptoms. They're neurological symptoms. You see double vision, movement of the eyes, Wernicke's, Guillain-Barré, which is twitching, and beriberi, they consider part of it, pain and weakness. There was a study that was done in 2004. They did a survey of 168,000 bariatric cases. 109 cases of neuropathy was found. 99 represented APGARs, as they called it. B12 or B1 deficiency were present in 40% of those patients. And the most common surgery was gastric bypass that caused it. Fat-soluble vitamin deficiency is following bariatric surgery. Seen a lot. It was a study that was done between NYU and a school in Australia. They found that after biliopancreatic diversion, 4 years after surgery, there was 69% of the patients had a vitamin A deficiency, 68% had vitamin K deficiency, 63% had vitamin D deficiency. Jejuno-ileal bypass, which was one of the older surgeries also, 6 years post-surgery, vitamins A, E, and D, these are all fat-soluble vitamins, 76% of the patients were deficient. Following bariatric surgery, vitamin A deficiency, well, you know, vitamin A is very much involved with the eyes. You got xerophthalmia, which is the dryness of the eyes, poor night vision, night blindness. We had one patient I have seen with night blindness. She didn't take her vitamins. She had been good. She stopped taking them for 6 months. And of course, what happens is the doctors don't see this stuff. They don't learn about nutritional deficiencies in medical school anymore because our wonderful country has such wonderful food, and you know, people didn't develop these things. 50 or 100 years ago, yes, it was a problem. Nowadays, it's not much. They consider it not a problem, but there are so many surgeries now that are causing this problem. They have to really be re-educated. It can cause total blindness too. Newborns with vitamin A deficiency from mothers who are vitamin A deficient after biliopancreatic diversion. Vitamin K deficiency symptoms are delayed clotting time, a lot of bruising, black and blue marks all over, and decreased vitamin K deficient proteins, which can be tested. In pregnancy, very often it was recommended that the patients not get pregnant for 1 to 1.5 years after surgery, but people do, and it's fine. It works out very well, except that they do need a lot of careful monitoring. There are differences in each trimester about what the baby needs and what's absorbed, and that has to be, the supplementation has to be adjusted. If the mother is going to breastfeed, a woman can lose 700 or 800 milligrams of calcium a day breastfeeding, and these people have difficulty absorbing calcium to start with. And anyway, there was one patient I had who was breastfeeding for a year, and women nowadays do like to breastfeed a long time very often. She developed a severe case of osteomalacia because she was giving so much calcium away and she wasn't getting enough vitamin D to absorb more calcium. I recommend shortened breastfeeding time, that they have to be careful not to cause themselves too much of a depletion. Okay, the blood tests, complete metabolic panel, a CBC, which is a complete blood count, serum ferritin, this is for all different kinds of surgeries. Serum transferrin, we talked about that, the iron. Homocysteine, done nutritionally. 25-hydroxyvitamin D, that's a test all of you need to get, whether you've had the surgery or not. Methylmalonic acid, which is a specific test for B12, blood lactate, B1 plasma, B12, and folic acid. B12 itself is not a very good test, but they do it together with folic acid, so you have to do it together. It's not a specific. Methylmalonic acid is specific for B12. TSH is a thyroid-stimulating hormone. Magnesium. IPTH is an intact parathyroid hormone. PT is a prothrombin clotting time. Serum retinol. And so my recommendations are, we need new RDI guidelines, recommended dietary intake, following the bariatric procedures. They don't have them, and they really need them because so many people are really in trouble. Requirement, this is something that I really would love to see, but I don't know if we'll ever see it, that bariatric surgeons take a nutritional follow-up course, because a lot of these surgeons love to do surgery and let the patients go and don't follow up. And the patients simply run into big problems afterward. The primary care provider should know what blood tests to order and how to interpret them, regular follow-up at 6 months, 1 year, and yearly after surgery, and lifelong supplementation of nutrients. Thank you.
You've been watching Food for Thought on MCTV. For more information about Diabetes University, go to diabetesaction.org.